Okay, so welcome back, people. We are on week 8, believe it or not, out of a 10-week schedule. So pretty close to the end here. Feels like it probably took forever to get there, but we are actually close to the end. So we just kind of push through 1, 2, 3 more kind of new topics, I guess. And I guess that really depends on how far along you are with the previous topics or how many new ones you have to push through. So if you haven't completed lecture exam 2, sure, think about that first. Don't start thinking about the new stuff. But once you get that done, we had one other one that was kind of due toward the end of last week. And again, due is a relative term. But the blood immunity in labs, where you kind of look at the different, compositions of the plasma versus the whole portion of the blood, which is the cells, and you memorize numbers like red blood cells, 4 to 6 million per microliter, and white blood cells, 4,000 to 11,000 per microliter, and platelets, 130,000 to 360,000 per microliter, and then once you determine what they're useful for, like red blood cells are useful for delivering oxygen, then it's a pretty easy assessment of what would happen if we had too few or maybe too many. Obviously, if we had too few, that's, indicating anemia, and you're not going to get as much oxygen carrying capacity, which is more of a better definition of anemia rather than just too few. But there would be clear signs and symptoms because of that. So it pushed forward into what we end up calling lab diagnostics, where you would test the values of certain things in the blood, and it's not just the cells. It would get further into stuff dissolved in the plasma. And again, if you know the basic function of a lot of these things, which isn't always clear cut, I get when you start looking at electrolytes, that's not something that's easy to remember. But if you know things like sodium and potassium and calcium are used in things like, say, depolarization and repolarizations of neurons, muscle tissue, and muscle tissue includes the heart, then you get the idea that if these levels are off in any one way, shape, form, or fashion, that's not good. Good question, Lauren. The other thing that we kind of did this week is, when I was going back and looking at how many people had completed that lab quiz, I think only maybe 2 people had gotten there so far. So what I did earlier this week is I went ahead and just said, don't worry about the Zoom meeting for muscles. Muscles, I was kind of on the fence whether I was going to add that into the final or not. So what I decided to do was, instead of having our class, I didn't mean to hit that button. Sorry, let me go back. So instead of having our class meeting under the normal Zoom invite, I just put a couple of questions in there about, what do I need to take from this chapter? And part of that could be possibly for the final. If I'm going to ask questions about muscles from the final, then I will stick to this. Mainly things like, what if somebody has a high CK or CPK test? Because that kind of goes along with everything else that we're trying to prepare for. So today, when we get into the urinary, we're going to do a lot of the basic stuff: normal anatomy, normal physiology, normal renin-angiotensin-aldosterone pathway. And then next Tuesday, we'll start talking about, well, when individual pieces break, how would that show up to us? And part of that's going to be through lab tests. So for CK and CPK, usually if these things are too elevated, too high, it indicates that we have some type of muscle damage. And muscle damage can come from a lot of different sources. So this is pretty, I guess, good general knowledge to have. It would be something that's useful because if somebody ended up having, say, an infection in the muscles, the muscle tissue would be damaged. And when you start damaging cells, certain things that we would expect to find inside of cells sometimes leak outside of cells, and it can cause the plasma levels to become elevated. So that's an example with CK or CPK. So creatine kinase or creatine phosphokinase. If those are high, that's usually indicating we have some type of muscle damage. It's also pointing out that we have, pretty high muscle inflammation, which would lead to then damage and the muscle tissues are being destroyed. So that's kind of an example of useful stuff that we will kind of take with us from the muscles without getting into the whole, here's how skeletal muscles work, because that just, it's one of those things where you're probably not going to find a lot of application for it in the real world, other than knowing basics that you could gather from other chapters like neuro, like what's depolarization, what's repolarization, again, what are some of the electrolytes that are used in that type of stuff. So again, these questions that we're seeing here from the muscles, those would be more general purpose stuff. So yeah, so if you're going to go back and look at it, you're more than welcome to. So in the module, again, just in case anybody's joining us and they're not sure what I'm talking about, we're on week 8 right now. Week 7, again, we had this little lab diagnostic quiz. It was only including one chapter, but because I pulled this quiz out, which was originally meant to be part of lecture 2, that kind of invaded this week here in which muscles would have showed up. So rather than spending a lot of time doing muscles this week, I just gave everybody the day off on Tuesday. And I said, hey, just look up some of these questions. That'll be great. These will be things that are going to be useful and applicable, and I might ask about in the future. But of course, I left the muscles PowerPoint here. So if you're still maybe confused about muscles from before and you want to know how they work, save the PowerPoint, use it. But I'm not going to be asking about things from, like, say, slide 4 of the PowerPoint unless it was specifically asked in these questions here. So hopefully that makes sense. Let's see, but summary, again, we're right here if you're only concerned about the here and now. So Tuesday, we didn't have an official meeting. That's when I posted those questions. I posted those probably Monday night. For today, we're going to start working on urinary, and that's going to lead us into our final sections, which I will make available for you now. So let me just publish some of these so you can see what's ahead. And essentially, we only have 3-ish new sections, kind of 4. But urinary, we're going to do today, the basics. Next week, we're going to do when the basics fall apart. So we'll talk about the diseases, similar to how we did heart. We did a lot of the basic physiology of the heart first, and then we looked at when the physiology breaks. So we'll do the same with the urinary. After that, so a week from today, we'll start working on digestive. And digestive, we're mainly just going through the sequence of events. And if anything happens to that sequence, what would happen? So a lot of things that end up happening with the digestive system could be, one of the tubes is inflamed and not working right. So what are we going to see because of that? Or one of the tubes is obstructed. So for example, if I end up having, say, an obstruction in the common bile duct, what would happen? What would we see in the patient? What are they going to be lacking at that point? If I have a backup that leads to inflammation of the pancreas, what are we going to see? How would that affect labs? What's going to happen to the patient? So once you know the basic walkthrough of the digestive system, which is kind of like tracing food through the digestive system, we'll talk about what happens when you get a blockage somewhere along the way or an obstruction, right? So like a gallstone could be an obstruction, a small bowel obstruction, a large bowel obstruction. Pyloric stenosis, anything like that. So, and then part of the digestive system, we're also going to throw the liver in there. So we'll talk about things like liver inflammation, like hepatitis. We'll talk about ways we get there. Like a lot of times hepatitis will usually come from a fatty liver that's due to alcoholism, but you can also have like a non-alcoholic related fatty liver disease, and that causes hepatitis. And if you have hepatitis, that's a problem, because that's basically saying we're going to have this general dysfunction of the liver. And then when you look at what all the liver does, that's a big deal. Liver and kidneys kind of work together to, I guess, make some of the chemicals that float around in our blood less problematic. So if we have something that's kind of toxic, the liver can detoxify it, and then the kidneys can eventually remove it, right? So if the liver is not working, then That's a big deal. And if you go back to, again, some of the blood immunity in labs, one of the labs it talked about in metabolic panels might be things like AST and ALT, and they sometimes have different names, but those are similar concept-wise to what I was talking about with the muscles. Like there's certain things that we find inside of liver cells that should be inside of the liver cells. But if I start to see them floating around out in the blood, that means they somehow escape the liver cells. Why are they out there? Maybe inflammation could explain that. So if we suspect that somebody does have a liver condition, which again, we'll talk about the liver with the digestive system, then we start to see elevated levels of things like AST and ALT in the blood. And then what can we predict from that, right? So again, you have to kind of look at bigger picture. What all does the liver do? Well, one of the main things it does is detoxify. So maybe it's going to lose some of its detoxifying ability. Another thing it does is it will convert energy sources. It'll convert fat to sugar and sugar to fat and all that kind of jazz. So again, we'll talk about that more once we get there. I don't want to spoil all the fun ahead of time. But one particular example, we might run into in the real world is if your liver is not working, you're going to have to change the way you medicate the patient, because I might not be able to convert the medication appropriately. I might have to give it to the patient in a different way, right? So anywho, and then the last topic we cover is cancers, sometimes called cancers and neoplasms. That's another name for that type of material. And we'll talk about, I think maybe top 10 I chose to go over. I can't remember, to be honest with you. But I'm pretty sure I just chose the 10 most common types of cancers that you see. Could be 12. Again, I'm not really questioning the idea of the chapter, but just how many I chose. But we'll get there when we get there. But anywho, that's an overview of what we're going to work on next. At the end of the week 10, so I think our last day is August 4th. That is when the final is going to be due. So I know we're kind of right up to the end right there when we get to cancers and neoplasms. So the goal is for you guys, as we're going through these things, we're in our last couple of weeks, stay caught up if you can. If you're not caught up at this point, go ahead and get caught up this weekend. So that way it frees up your next 2 weeks just for study for the finals. And even though the finals are going to be kind of open notes, open book, open whatever you want to open, you still need to have prior knowledge so you know where to look. You know what I mean? That's a lot of what school's about nowadays, because knowledge is out there. We don't have to receive it from a human being anymore. But where do I look for that knowledge? So the better you stay caught up, the easier it's going to be once we get to our final. And I'll discuss the format of the questions and stuff probably next week. So, but anywho, I've already opened up my urinary PowerPoint. I'm going to switch screens to that real quick. I'm not going to stay on the PowerPoint. We're going to talk about, probably in this particular order, we'll talk about the anatomy first. We'll talk about basic functions. So you can find all this stuff in the PowerPoint. I'm going to do a lot of it on paper. We're going to talk, going back into anatomy, we're going to talk about parts of the nephron, like what's the role of the glomerulus, what's the role of the tubular system. We'll probably talk about capillaries at that point as well. That's why that slide's kind of thrown in there. So capillaries, we'll draw our normal picture again. We'll talk about filtration, reabsorption, what's the glomerulus doing and how does this apply to kidney function. And then we're going to talk about another portion of nephrons called the macula densa, which would be very difficult to see with this picture. But again, another portion of a nephron is something called a macula densa. I think we can kind of see it a little bit better maybe here, this little loop right here. And again, this is just a diagram. This isn't necessarily anatomically accurate in every way, shape, form, or fashion, but if this is a descending limb of the loop of Henle and this is an ascending limb of the loop of Henle, as it passes in between the afferent and efferent arteriole of the glomerulus, you end up getting another portion of the nephron that's usually not mentioned here, right, called the macula densa. And one of the most important roles of the macula densa which let me see if I can find that in the notes for you. Here is it can lead us to that renin-angiotensin-aldosterone pathway. And the reason the macula densa might initiate a renin-angiotensin-aldosterone pathway is because of decrease in GFR. So we'll talk about what's GFR, how is GFR established, and that'll go back into the anatomy, right? So it all ties in together. And then what's going to end up happening if the GFR goes down? Well, then my kidneys can't function the way they're supposed to. And one of the main functions of the kidneys, of course, is to be able to remove chemical waste from the body. So waste will start to accumulate, and that's essentially a sign of kidney failure. So we don't want that. And the renin-angiotensin-aldosterone pathway is trying to prevent that. So there's a lot of implication today. This is one of those chapters that are super useful. It's a super important chapter. It's one of those things you run into a lot with patients, especially people with chronic diseases like diabetes. One of the reasons most diabetics die is because of some type of chronic kidney disease, right? The kidneys eventually just give out. So we're going to talk about all the basics today. Again, it'll all make sense when we do all that. And then next week, we'll go back in and we'll start to pick and choose different problems, right? Like part of the renin-angiotensin-aldosterone pathway, of course, is for the production of aldosterone. It's not the only way we can produce aldosterone. Decrease in GFR, believe it or not, it's not the only way we can run into the renin-angiotensin-aldosterone pathway. But if this process isn't working, what would we expect? So a key to understanding the urinary system is just knowing how all the basics works at the most basic level, and then you can just predict what would happen when it falls apart. So if you just know the stuff I teach you today and Tuesday of next week, you'll be good pretty much forever. Okay. So I'm confident in that, but it is not a chapter that should just be kind of pushed to the side. It's top 3 most important chapters we do for sure. So again, what I'm going to cover today, just to give you an outline, I'm going to talk about the anatomy today. I'm going to talk about basic functions, and all this is in the notes, but I'm just going to do it on paper. I think it's easier to follow along if you don't have it all in front of you up front. We'll talk about basic parts of the nephron. So the glomerulus, the tubular system, you know, if we're subdividing it in half, you know, what does one part do versus the other? Because when you have renal failure, sometimes it's just the glomerulus that's affected. Tubular system's fine. Or sometimes if you have some type of intrinsic renal failure, it's the tubular system that's broken, but the glomerulus is fine. How do you tell the difference? So we'll break it down into its basic parts. Again, we're going to throw in capillaries because a big part of the nephron is the glomerulus, which is just a big old capillary. So we have to understand capillaries again. We will pick back up on the nephron by talking about the macula densa, because that's where the juxtaglomerular cells are. You also have macula densa cells. Maybe I'll throw that in there, maybe I won't. We'll talk about the concept of GFR, which will tie us back into anatomy, because you have to have a certain amount of filtration for the kidneys to be able to remove chemical waste. And part of that filtration ability comes from the high amount of blood volume that the kidneys receive because of that renal artery. So that ties back into the anatomy. And of course, blood flow and pressure, we talked about that. There's different ways that we can alter how much blood an organ receives or how much pressure it's receiving. So if we don't have enough pressure, we can't maintain enough, CHP. And if we can't maintain enough CHP, we can't maintain enough GFR. And if we can't maintain enough GFR, then the renin-angiotensin-aldosterone pathway kicks in. So sounds complicated at first. Once we break it down into its little pieces, it's pretty easy. So that is the goal. So first, basics of urinary system. A lot of times you don't worry about the anatomy of the urinary system too much in a lab because there's really not much to it. So that's good for us. So I think if we were to spend a whole lab talking about the urinary system, like doing like fetal pig dissection, the lab would take about 6 minutes. We're like, hey, here's kidneys. They sit what's called retroperitoneal. So, that might be a word that comes back and haunts you one day if I don't mention it to you. But retroperitoneal basically just means they sit behind the rest of the abdominopelvic cavity. Like it has its own serous membranes, it's behind that. And once you get through that peritoneal membrane, like say parietal peritoneum, once you get through that membrane, you can see these things prominently sitting back there, and they're right up against the back. Usually kidneys will be somewhere between, like say, the T12 to L2 range. So they usually hover somewhere between the last thoracic vertebra and the second lumbar vertebra, sitting up against the back wall with a little bit of muscular protection, a little bit of rib protection, and fat usually would cover some adult kidneys. Obviously, you wouldn't have seen that in the fetal pig because they're not adults. But you got these two kidneys sitting there. And another thing you might have seen, and again, it doesn't matter if you've seen it or not, that's why I'm going over it with you on a picture, is these things are connected to the abdominal aorta through a very prominent vessel called the renal artery. And the renal artery is very unique for several different reasons. So if this is, say, my kidneys right here, this is the abdominal aorta, so abdominal aorta. And here's my renal arteries. Just beneath that, if you want it to keep going, your aorta will eventually bifurcate and go on to form common iliacs. And then the iliacs will go on to form internal and external, and that's going to supply all the lower extremities in the pelvis. But this occurs first. And the unique thing about the renal arteries, so this is a renal artery right here, is they're very short and stout, right? So renal arteries, so here and here, are very short, thick arteries. So they have some good diameter to them. So a lot of blood under a lot of pressure is going to these kidneys. So in comparison, another vessel you might have learned when you were learning like the anatomy of, say, the abdominopelvic cavity. Let's say here's our abdominal aorta. Think about the size of the liver, the spleen, and the stomach, right? How big they are. And they all share one trunk coming off that abdominal aorta called the celiac trunk. And that celiac trunk goes on to form an hepatic, a splenic, and a gastric artery, each of which are all coming off one vessel, right? But they have to share one vessel for a liver, right? A spleen and a stomach, right? Which are like this big. And then you have these kidneys down here that are saying, ha ha, look at us, right? And that's not the best relative size picture right there, but you get the idea. The renal arteries are unique because they're just dedicated to the kidneys. They are a direct branch coming off that abdominal aorta. They're very short and they're very stout, right? So kidneys end up receiving a lot of blood because of that. And eventually, when we start talking about different types of renal failure, if there's anything that's called pre-renal failure, it's basically a problem of getting blood adequately to the kidneys, right? So if I have any problem back here, like say the heart, the major vessels, the renal arteries themselves, like let's say I throw a clot in the renal artery, that can cause pre-renal failure. That's a problem. But the basic idea is my kidneys are going to be receiving blood from renal arteries. And renal arteries are very short, very stout. A lot of high pressure blood goes into those kidneys. Okay. So we can talk about consequences of that later. But anywho, once the kidneys receive this blood's going to kind of come in here, kind of go around the outer portion. And nephrons are going to be sorting through this blood. And one of the basic functions of the kidneys is to remove the chemical waste from that blood that's entering. And once we've removed the chemical waste, venous blood will go back in, and you're going to have an inferior vena cava that's going to attach to the renal veins. But again, let's not worry about that right now. And that filtered waste portion will eventually leave, and they're going to go out through these things called ureters. So that's all the tubing that's kind of attached to the kidneys, but that looks messy. So let's clean it up a little bit. And when we look at the urinary system by itself, there's only a couple of associated pieces. So let's remove the abdominal aorta. Let's remove the renal artery and the renal vein real fast. And let's just look at what's part of the urinary system. You have these two kidneys, which are receiving a high proportion of blood. About a fourth to a fifth of all blood in the body goes to the kidneys per day, right? Per minute, per hour. So they receive a high proportion of blood, disproportionate to their size. Because kidneys are not a fourth or a fifth of the size of the body, but they're receiving about that much blood. Why? Because they have a much bigger, larger artery directly attached to them. So once they clean that blood, one of the things the kidneys are most known for is to be able to remove chemical waste. So where's that waste going to go? Well, we're going to send it to the bladder, which is down here, right? And that bladder is going to hold that waste until we're ready to empty the bladder, and it's going to exit through something called a urethra. So what's connecting the kidneys to the bladder are things called ureters, right? And ta-da, that's the entire anatomy of the urinary system right there, right? So if you're just talking about the urinary system, what's the basic anatomy? You have the two kidneys, which we usually refer to as renal, right? You have two ureters. So these two things right here are ureters. I just always say it in the plural, just to remind me that there's two ureters. You have a urethra, right? You have only one. There's a urethra, two ureters, right? And then you have your bladder. So easy peasy, that's the urinary system. Why do we care about the basics of anatomy? It's simple. If you have looked at your blood immunity in labs, let me see if I can find it real quick. Download this real quick. Again, I'm not shaming you if you haven't looked at your blood immunity in labs just yet. I'm just saying, you might remember there was a particular slide in there that talked about something called nosocomial infections. That looks like it right there. I put the little dun-dun-dun, little sound tidbit in there. And you will notice right beside UTI, you see most common type of nosocomial infection is a urinary tract infection. Why? Because we start to stick catheters into that system, right? So why do we care about this system right here, which is very basic, not a lot of parts? It's because it's open to the outside world. So this opening right here, which we call the external urethral, because this is the urethra orifice, because it's an opening, is open to the outside world. So when stuff starts going from the outside world into that opening, that can be a problem because it could work itself back. The nice things about the urinary system, though, is they're pretty self-cleansing, because when I think about where does the flow come from, well, it's coming from cleaning out chemical waste from the blood, which is entering this way, and all the flow of the waste is going this direction. So it's a self-cleansing system because the flow is always pushing outward. So a lot of times, even if I do have some bacteria entering into the urethra, it'll usually clean its own self out. But what if that bacteria somehow gets further up in here, right? And with females, that's not difficult because the female urethra is much shorter than the male urethra, right? Males obviously have a longer urethra because it has to go through the penis. Females don't have a penis, right? So the urethra is much shorter in a female. So females are going to be much more likely to have urinary tract infections. But again, the most common type of nosocomial infection, so infection that people get by receiving healthcare, usually in a hospital, is a urinary tract infection, right? And it usually comes from sticking a catheter up that urethra, right? Because any bacteria that could have been anywhere along here that's normally getting washed out has now been carried way further up into the system. So now it's harder to wash it out, right? And if you throw in a couple of like complicating factors, like maybe they have real sugary urine because of diabetes, now the bacteria can thrive, right? Or maybe my pH is off. That can cause bacteria to thrive. So different medications could possibly increase your likelihood of having urinary tract infections. But again, the most common type of nosocomial infection is a UTI. What are we going to see with that? Just follow the system. So if these are kidneys, right? They are not the closest to the opening, thank goodness. The urethra is. So if I do end up getting a urinary tract infection, what are the first signs and symptoms that we're going to see? Probably it's going to start with urethritis, right? Inflammation of the urethra. And when you start to get urethritis, usually you start to get a burning sensation, right? When you void the bladder. So when you pee, it burns. Okay. Hold on. If you hear a little clicking noise in the background, Oscar is giving himself a manicure. And he's also watching Stranger Things, and it was getting too loud. So first sign and symptoms of possibly having a urinary tract infection could be burning upon urination, so urethritis. If that makes itself further back in here, that's a problem. You can end up getting something called cystitis, which usually implies that your urinary bladder has now become inflamed. If that progresses even further, you can get urethritis, right? Sometimes they just get rid of this and call it uretitis, right? Uretitis. But urethritis is the big word. It's just basically saying I have inflammation of a ureter. Chances are if you have cystitis, you're going to have suprapubic pain. So above the pubic bone. Sometimes that's called hypogastric pain, but again, context, we would call it suprapubic because we're talking about the urinary system. But if you have suprapubic pain, like if something were to put pressure above your pubic bone, like you ever had a full bladder before and somebody pushes right there and it feels uncomfortable, multiply that by 10, right? So that would be like suprapubic pain. So that might be indicative of cystitis. If it continues to go up further and gets into ureters, then you're probably going to have flank pain. And again, that can continue into the kidneys. And then if the kidneys themselves are infected, then we might call that nephritis, right? And nephritis can lead to a type of acute renal failure, right? So it's very bad news. But that's the basic idea of why we learn the anatomy. And the reason that I was pointing out to you that urinary tract infections, so if I have an infection that's going up into the system, but UTIs is the most common, so MC stands for the most common, that's a superlative. And simple, I guess, advice I can give you is keep a little page of all the superlatives you ever run into, right? Like if we talk about in anatomy, the hardest substance in the body is tooth enamel. Just write that down on a piece of paper called superlatives. So superlatives are anything that's easily distinguishable because they are the ESTs of something. They're the best, the worst, the hardest, the softest, the biggest, the slowest, the fastest, the divides most quickly, divides the least, whatever. Anything that is an EST is a superlative. Just write them all down on one sheet of paper. So when you get into things like infections, that's a great one to put on a superlatives page. So what's the most common type of nosocomial infection? Urinary tract infections. Why do we get urinary tract infections so easily in the hospital? Because of catheters. And that's basically just following this idea. If I have a system that's open to the outside world and we start adding stuff from the outside world into that system, that can be problematic. Okay. If you ever get asked, so again, we kind of do this in my Anatomy 2 class. So this is all repetitious, which is good. But if you ever get asked, what is the most common cause of a urinary tract infection? They're not necessarily asking you the method in which the urinary tract infection was obtained, but the causative substance. So if you ever get asked what's the most common cause of urinary tract infections, they're sometimes looking for the particular organism. So you would say E. coli. Okay? But again, there's two superlatives right there. And superlatives are easy test questions on like board exams. Because when you take a national board exam, the idea is you're going to be adequately trainable once you get to the place you're going to work. It doesn't mean you're ready. It just means I have proven that I have adequate knowledge that I'm trainable at that point, right? And some of the things that we should at least be aware of are the most commons, right? Because what am I most commonly going to run into? I need to know that stuff. So even this, if this is out of your field, it doesn't make any difference. They'll ask you about it, right? So if you get asked what's the most common, Oscar, most common type of nosocomial infection, which is an infection that we can receive from the hospital or health care, that equals a UTI. How? Usually from catheters, right? Where they stick a tube up your urethra so you can void your bladder without you having to consciously think about it, right? But if they ask you what's the most common cause of urinary tract infections, right? then the causative substance is usually E. coli. I mean, of course, it doesn't have to be, but again, it's the most common cause. So MCC usually stands for most common cause. And again, this is why they tell you, if you're a female, to wipe in a certain direction. You know, you don't wipe going from the anus toward the urethra, you wipe in the other direction because that's where the E. coli is mainly originating from, right? But E. coli is found on the skin everywhere. Fun stuff, fun stuff. In the PowerPoint, if you want to see better pictures than what I drew, we have those too. So this, oops, I didn't mean to jump on that slide. Let me get rid of that. So here we go. So if you get into the urinary renal PowerPoint, third, fourth slide down. Okay. So here we can see the kidneys. Here's the renal artery. Here's the renal vein. Here's the ureter. Here is the bladder. Here's the urethra. So we just cleaned out all the rest of that stuff. It also gives you stuff I wrote on the sheet of paper. So last thoracic vertebra to upper 3 lumbar. So this one's saying T12 to L3. That's good enough. Right. And it tells you the different parts. So you got kidneys, ureters, bladder, urethra. So it's all in there. Right. And then the rest, it starts to get into these different parts. I might mention that when we get into the nephron. So cortex, again, medulla, the pelvis, the sinus. If you want an easy way to remember like cross-sectional anatomy, or here the kidneys kind of been butterflied where we're removing the front half and you're kind of looking at the back half. The easiest way when I was in school to remember which section is which is it goes in alphabetical order if you start laterally. So you have a cortex, a medulla, a pelvis, a sinus, right? You know, of course, cortex goes all the way around. But again, if you start out here, it's alphabetical. So here's cortex, medulla, pelvis, sinus. And sometimes that becomes, you know, test questions in anatomy of like where do nephrons originate? They usually start in the cortex, right? But what about the loop of Henle and the collecting duct? Well, they drop into the renal pyramid, which is what makes up the medulla. But that's all the anatomy there. Okay. Basic functions of the kidney. Here's a list. I don't think you probably need that list. But one of the main functions, let's reorganize it a little bit. One of the main functions, so functions, FXN, function. So if you want to shorthand things, again, I do this all the time in my class, so my students are used to seeing these abbreviations, and they're probably like, I'm glad you finally explained this. I had no idea what you were writing. But when you start writing notes, it's good to learn shorthand. So function, section, cross section, right? Saves you a lot of time and energy. So anything that sounds like unction, just put an X in, right? But functions of the kidneys, which are the main working part of the urinary system, remove chemical waste is by far the most, I guess, important and remembered part of kidney function. So remove chemical waste. And when we're removing chemical waste, it's removing it from the blood plasma, right? That's where it's coming from. So if you're ever wondering what chemical waste are they talking about, they're talking about the chemical waste that's floating around in the blood plasma. And sometimes we refer to that as metabolites. You know, again, the basic idea of blood is twofold. I'm trying to deliver stuff to the cells that the cells need to metabolize, live, and make stuff for the body, right? And at the same time, I'm going to produce waste, which we sometimes call metabolites. And when we produce that waste, sometimes the liver will alter it from one form to another just to make it safer for floating around in the body without damaging stuff. And then the kidneys can remove it. And the idea of homeostasis is we're going to remove it about as quickly as it's being made, right? So that's kind of nice. And we're trying to maintain certain fluid electrolyte balances. We're trying to maintain certain nutrient levels versus waste levels. There's always going to be waste in the blood because we're producing it just as fast as we're removing it. But we're trying to make sure it's not building up, right? It's not becoming in too high quantities. So the kidney's job is to remove that chemical waste as we're making it, right? And to do that adequately, some other functions of the kidneys that tie directly into this main function. So we'll just put a star beside it because that's the main function. to do that adequately, kidneys need to be able to regulate blood pressure, right? They need to be able to help regulate and control blood volume or fluid volume, right? I mean, you could just say fluid volume in the body, but blood volume is a direct reflection of fluid volume. So I'll just put both on here. Because if I don't have adequate fluid volume, then I can't maintain adequate blood pressure. We can kind of, I guess, compensate for that by changing the amount of vasoconstriction versus vasodilation. So I can add more pressors if I need to. So even in a low volume state, I can add more vasoconstrictors and that'll still help maintain blood pressure, but it's just easier if we have proper volume, right? I don't have to squeeze so hard if I just have proper volume, because the volume itself will exert pressure on the surrounding vessel. And it's this volume and pressure that allows us to filtrate into the nephrons, right? So we'll get into that when we talk about nephron. So these three all tie in together very well, right? And of course, within that fluid volume, we need to regulate a lot of the stuff floating around in it that we do need on a regular basis. It regulates electrolytes as well, because sometimes the volume follows certain electrolytes. Like, for example, the big electrolytes that we think about, sodium, potassium, we can even throw in chloride here. These two, believe it or not, are the main things that water follows. So if the kidneys can't regulate electrolytes appropriately, like sodium and chloride, then it's going to have a very difficult time regulating the blood volume, because the fluid will follow these electrolytes, just like water loves salt, right? That's what we have right here. And those are both part of the ECF. So, but there's other functions to this other than just attracting water. You're also going to use sodium, potassium, calcium, right? Magnesium for, depolarization, repolarization phenomenon. So if I'm not regulating these things, the proper fluid electrolyte, osmolarity, we sometimes call it, then neurons aren't going to fire appropriately. Skeletal muscles won't work appropriately. And the heart, which is probably the most sensitive to these things, won't work appropriately, right? So again, all this kind of ties in together, because waste is a relative term, which I'll describe in just a minute. So these all tie in together. These are some of the main functions of the kidneys, but you also have to remember some of the more obscure ones, because they will pop up sometimes. And sometimes the obscure ones are the reason a patient presents with a, kidney problem. Like a lot of times, some of this stuff's being all jacked up while the kidneys are failing, and the patient doesn't even notice the signs and symptoms other than maybe they're swelling or the fluid volume's not right? Maybe they're thirsty all the time. Maybe they have cravings for salty foods, stuff like that, but they don't attribute that to the kidneys. But then when they present to the doctor, they're just tired all the time. And that might be the first sign and symptom that actually drove them to the doctor, right? And so the reason you sometimes have a lot of fatigue when you have renal failure, again, is your fluid electrolyte balance is all jacked up, but the kidneys also produce erythropoietin. And if I can't produce enough erythropoietin, then I'm not going to be able to produce adequate red blood cells. And as you learned back in the blood immunity and lab diagnostic, the main job of red blood cells is to deliver oxygen-rich blood so the cells can metabolize. And with that oxygen, I'm able to release energy. And if I can't release enough energy, then I'm going to be fatigued all the time. So if the kidneys aren't functioning and we're not producing enough erythropoietin, then you can become anemic. And then another kind of unusual one is it activates vitamin D, okay? Activates vitamin D. So vitamin D, real quick subsection to that, 3 parts in the body are needed to adequately produce and make vitamin D work. You need healthy skin and UV exposure, skin plus UV light, right? Melanocytes can actually produce cholecalciferol, which is like an inactive version of vitamin D. But then you need a liver to partially activate it, and then you need a healthy kidney to continue to activate it. So if either one of these are not functioning appropriately, then we will not have adequate amounts of vitamin D. Right? So luckily for us, a lot of food is fortified with vitamin D now, but again, you still need to be able to convert it to its usable form. So if I have liver disease or kidney disease, then we're eventually going to have bone issues. And yeah, so this section, I usually tell people, is where you start to see multi-system dysfunction occurring because one organ's not working appropriately. But that's the basic functions of the kidney. So again, you can see this on the PowerPoint right here. Next thing we want to do is, so we talked about the anatomy, we talked about the functions, we're going to talk about the nephron. And when we talk about the nephron is at the microscopic level. A lot of times it's actually what you're seeing when you look at simple cuboidal epithelium. So let me just show you that real quick. Like, for example, if I am, let's turn on the Google machine real quick. If I just type in histology, simple, oops, not dimple, simple cuboidal epithelium, I guarantee you we're going to see a nephron here. That's a tubular system of a nephron right there. That's a tubular system of a nephron. I think that's basically the exact same thing. That's a glomerulus right there. Here's a tubular system right here. So this is something you've physically seen with your own eyes before. Like, sometimes I'll use this slide when we're studying histology in anatomy and physiology 1, like biology 108, when I'm showing you simple squamous epithelium. So that's simple squamous epithelium, but this is all simple cuboidal epithelium. What are we looking at? We're looking at a nephron cross-section. So yeah, so that doesn't look a whole heck of a lot like, so that and all this stuff, it's cross-sections of nephrons. That doesn't look a whole heck of a lot like this. That's what it is. It's one of these that's been cross-sectioned kind of like that, and you're looking down on it. Isn't that wild? But these tubular systems are so convoluted. It goes back and forth. That's what ends up giving you all those little holes from above. Because when I cross-section it right here, now I got like a little circle thing right there. I got a little circle thing right there. I got a little circle thing right there. 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 So when you go back and look at the histology, there's all those circles where you cross-section those tubes. Isn't that wild? It's crazy. But how did people go from this to that? That's pretty good imagination. They're like, oh, I bet this would look like this in the real world. So these are at the microscopic level. I don't know the actual number of how many nephrons we have in the body, but I've read 2 different sources. And one source says that we have about 1 million nephrons per kidney. And another source says we have about 1 million nephrons total, right? So that would be about 500,000 per kidney. But that just gives you an idea that these things are pretty small and numerous. And together, they're going to work to do all those functions that I showed you kind of at the top before, like the removing of the chemical waste, even the maintenance of blood volume and pressures. They're responsible for all that stuff. So nephrons, we call the functional units of the kidneys because they're doing the basic roles that we attribute to the kidneys, and they're the smallest individual pieces that can do that. So the nephrons are the functional units of the kidneys, so they get a lot of discussion. Usually when we start talking about nephrons, we draw a simple version first, and the simple version I draw usually is more spread out. I don't like to draw something that looks like this. That's a little bit too convoluted. We usually draw something simple like that, right? And we'll just label it. Here's proximal convoluted tubule, loop of Henle, distal convoluted tubule, so we don't have to draw all these wavy convoluted portions. But it's meant to diagram it so we can look at it from a functional perspective, right? So first part of a nephron that we typically draw, and it's going to end up being the first functional half of a nephron, is the glomerulus and its surrounding structures. So a glomerulus is basically just a big cluster of capillaries, right? So here's the glomerulus right there. Here's our glomerulus, and your glomerulus is a big cluster of capillaries. So I'm just going to put this is capillaries, caps. When we form capillaries, which we'll show a diagram of that in a minute, you usually are led into a capillary by an arteriole, right? Like you have artery, arteriole, capillary, venular vein. So here's the arteriole that's leading into that formation of the glomerulus, and we call this an afferent arteriole because it's heading toward, right, some type of processing place. Like in neuro, afferent's heading towards CNS to process information. Here, we're sending blood to be processed by the glomerulus. So afferent's kind of heading in toward that. So this is an afferent arteriole heading in toward the glomerulus. Here's an efferent arteriole coming out. And eventually this ends up becoming what's called a peritubular capillary, but we're not worried about that right now. So here's an efferent arteriole. And surround that with a capsule. So it's encapsulated so we can capture what's going to come out of this thing. And the capsule is called a Bowman's capsule. There you go. And that's the first functional half of a nephron, which really doesn't look a whole heck of a lot like these pictures, right? But it's just showing this part right here. It's just this part. So let's just assume this is my afferent arteriole glomerulus. Here's my efferent arteriole, which that's what it has to be because it's going on to form what's called a peritubular capillary. Here's the Bowman's capsule. Here's the glomerulus itself. And believe it or not, this is the first functional half of a nephron, even though it doesn't look like it's half. But it's a functional half, not a physical half. So I'm just going to draw a dotted line right here. Boop, 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 boop. And all together, if you want to, we can call this one thing. I would prefer you remember that we have a glomerulus, which is a big cluster of capillaries, led into by an afferent arteriole, exited through an efferent arteriole and surrounded by a Bowman's capsule. But if you don't have time to say all that stuff, you could call this a renal corpuscle. So a renal corpuscle is basically this encapsulated glomerulus. So corpuscle just means you're encapsulated. So it's talking about the Bowman's capsule surrounding this glomerulus. So altogether, if they ever mention a word called a renal corpuscle, they're talking about all that stuff. And that's the first functional half of a nephron, which are the functional units of the kidneys. So they're going to be responsible for doing the majority of the work of the kidneys. And there's a lot of small nephrons. So the second functional half of the nephron, of course, is all those convoluted tubes, right? The loop of Henle, right? The collecting duct. So we're going to draw ours very simplistically. So this is going to be our proximal convoluted tubule right here, which we're just going to abbreviate PCT. This is going to be our loop of Henle. And a loop of Henle actually has a thin portion, a thick portion. It has a descending portion. It has an ascending portion. But right now, we're just going to call it I'll write it out, loop of Henle, just so you see the word. Be familiar with that word because even in the pictures in the PowerPoint, it'll call it loop of nephron. That is not typical of most higher level books. Usually it's called loop of Henle. So descending limb, ascending limb, a loop of Henle. I'm just mentioning that right now. Here is a distal convoluted tubule, but DCT because this is all written out in the notes. And we're trying to diagram, which means make things simpler than what they actually are. That's what diagrams are for. And this is a collecting duct. If you ever make a diagram more complex than the original, you're doing it wrong. Right? Diagrams are meant to make things simpler so you can understand them. So proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct, all together, that makes the second functional half of a nephron, which we call the tubular system. Okay. Easy peasy. So functionality wise of the nephron. Simplified version, afferent arteriole, glomerulus, efferent arteriole, Bowman's capsule. There we go. Here's a nephron. In the glomerulus, right, or in our renal corpuscle, if you will, this is what's referred to as my major filtration unit. So my renal corpuscle versus my tubular system what are the roles? And it's not like they're fighting each other, they're assisting each other. What are the roles of each functional half? Remember, I drew a little dotted line right there. So here's one functional half right here. Here's the second functional half right here. The role of the renal corpuscle is to filter. That's what it does. Right? Its job is to filter. Right? So this glomerulus, which is a capillary, is going to filter. And it's filtering things based off size, not necessarily substance. Right? It's based off size, not what it is. Right? So anything small will leave this glomerulus and be picked up by that Bowman's capsule. That's why it's encapsulated, so we can capture what's ever being filtered out, right? So when it comes from a kidney perspective, we're going to be filtering stuff from the blood plasma here, and floating around in that blood plasma is going to be a mixture of nutrients and metabolites, right? Again, that's something that might have been discussed in the blood immunity lab chapter. But again, even though those might be very generic terms, we can just basically at this point say we're going to filter out both good and bad substance. Okay, we're not being discriminative right now. The renal corpuscle doesn't have that power. It's using passive transport mechanisms. It's just filtering based off size. So what's being filtered out could be considered useful, nutrient, could be considered bad, like a metabolite or waste, right? But here's where we're going to come back and talk about waste real quick, right? So before we get into, well, why did we filter out good right here, you know, and bad when we should have just got rid of bad? There's a reason for that. We need to talk about the word waste, okay? Because bad is the type of waste we're trying to get rid of, but waste will vary depending on the state of the body. So waste, when we're dealing with the urinary system, okay, waste is anything that is in excess, right? Anything excessive is considered waste to the urinary system. So if I have too much B vitamin, that's excessive, we'll pee it out. If I have too much sugar and it's in excess, I will pee the excess out. Not always, that's why diabetes is a problem, but eventually we'll get past what's called the renal threshold and you will start seeing some of it come out, right? So waste is anything that's in excess. If I have too much sodium, we need to get rid of the excessive quantities because that's going to cause problems. You would be hypernatremic, right? So waste is variable, right? Sometimes things are going to be considered waste that might normally be considered nutrient. And sometimes things might be considered waste that are true waste, right? Like creatinine. Creatinine's always excessive, just if it shows up. So we'll always get rid of it, right? So once it shows up in the kidneys, we're going to get rid of it every single time because it's always waste. But what about things like sodium or potassium or calcium or magnesium? You know, some of these electrolytes, are there going to be times, you know, when we might have the right amounts in our body? Sure. But are there going to be times where we have too much, maybe? Sure. Right. So at that time, it's going to be considered waste, right? So what's one of the jobs of the kidneys? It's to maintain proper fluid volume and electrolyte balance. So how am I going to maintain this balance? Well, we're going to conserve it. If we don't have enough, we're not going to pee out any. But if I have too much, that's considered waste. We're going to get rid of it. You get the idea? So in the kidneys, the word waste is not a fixed thing. It's dynamic. Another example. When you're trying to maintain pH, pH is another thing that's kind of understood when you are, and it's part of the PowerPoint. I didn't put it in our little notes, A, because I forgot, but B, because it's understood as part of electrolyte balance. So when you get into, one of the roles of the kidney, so again, functions of the kidneys, one thing it's going to do is maintain pH. Okay, and pH is part of electrolyte balance, because a lot of times when we talk about pH regulation in the body, there's several things that contribute to it, you know, positively charged ions versus negatively charged ions. But to keep it simple, it's how much of this is floating around and things that could remove this floating around. So if I have too much hydrogen floating around in the body, then the body has become acidic, right? And we would have to pee this out at a higher rate to bring that acidity level, I guess, down or bring the pH up. I know that sounds kind of word salad, but still, that's the way it works, because on a scale of 1 to 14, right, the more I head toward 1, the more acidic I become. It basically means I have more of these floating around, right? As I start to go up toward a pH of 14, I have fewer of these things floating around. So when you're talking about acidity in the body, it's lower on the pH scale, right? But it's based off hydrogen ion concentrations. So the more of these I have, the more acidic I become, the lower the pH is, because I'm fewer spaces from zero rather than many spaces from zero. Okay. So again, I know that's probably getting too mind, numbing, because you've heard it so many times, but let's say that here's my glomerulus, and my glomerulus is kicking out everything small, right? So let's say we're kicking out hydrogens, and we're kicking out chlorines and bicarbonate ions. Let's say we're going to kick out some sodium and potassium, all that kind of stuff. Those are all small things. Electrolytes, of course, are small. I mean, we're talking about individual atoms that have lost electrons, or maybe gained an electron. So that's pretty small. They're going to be filtered out. We'll filter out, glucose. Glucose is small. I mean, it's not as small as these things, but still, I mean, we're talking about like 6 carbons, 12 hydrogens, 6 oxygens. That's pretty small to me. We'll kick out amino acids. We're going to kick out true waste like creatinine, right? But what determines whether these things are waste or useful is how many there are. If I have too many of these floating around at that time, they're considered waste. But the glomerulus can't discriminate between, good and bad. That's what they're going to filter out, is both good and bad, because they're just filtering out based off size, and all these things happen to be small. But once I pass it into the tubular system, now the tubular system, which is highly discriminative, says, well, I've got a bunch of these in here, and I've got a bunch of these in the body. We need to go ahead and keep these inside the tubular system and get rid of them, because at this time they're waste, right? And one thing that might help me to buffer this solution, which is already too high in acid because my body is in a state of acidosis, is when I do filter these things out and I kick it in the tubular system, let's go ahead and reabsorb them as quickly as possible, because these I can keep, and it's going to make my acidity levels less, right? Because they can essentially buffer this solution or reattach to those hydrogen ions, right? So during a state of acidosis, kidneys will reabsorb bicarbonate at a high level, and they're going to keep hydrogen ions in the tubular system, and they can actually add more hydrogen to the tubular system, right? But the glomerulus doesn't get to make that call. It's going to filter out things just based off size. The tubular system will then discriminate whether it's good or bad for us, right? But the glomerulus will filter out both good and bad and hand it over to the tubular system to make those decisions and then handle it appropriately. You kind of get that idea? So if my pH is all messed up or jacked up, then I'm going to get rid of the stuff that's going to contribute in the wrong direction. So if I'm too acidic, we don't want to keep hydrogen. We want to get rid of hydrogen. Yes, sir. Question.
What happens, so if you administer sodium bicarb, what happens to the kidneys if they're in if you give sodium bicarb and they're in acidosis?
Sure.
Does it just put more bicarb in the system?
Sure.
And
absolutely. Directly. Because when you have
sodium
bicarbonate,
is the sodium then in excess, so it gets put into the tubular system, or does that get absorbed?
It just depends on how much you already have. And if there is too much, we'll go ahead and get rid of that too, but we're handling the bigger issue at the time. So what's going to end up happening is the sodium bicarbonate, it joins together because it's ionically bound compounds, right? With the Na plus and the HCO3 minus. So it'll negate those two bonds because that's what's holding it together. But this ends up acting like what's called a spectator ion. So it'll break off, and then that'll free up bicarbonate ion to act like it is, which is a buffering system, and it can pick up excess hydrogen ions. So when these things join together, you'll essentially get H2CO3 again, which is carbonic acid, but the hydrogen has been removed from solution. Therefore, it's now acting as a base. You see what I mean? So if we have excess sodium now, that's fine. The kidneys are well designed to get rid of that excess. It's a normal ECF ion, so we'll pee it out if it becomes excessive. Isn't that neat? But essentially, you are helping the kidneys out, because rather than just having to reabsorb, pee, we've sped up the system, because this is going to take forever, right? But let's just assume that you have lung dysfunction and your lungs can't help you out. The kidneys take a long time, even though they're very thorough. So sometimes we have to intervene and add more of something faster than what the kidneys could reabsorb, right? Very slowly. You know what I'm saying? But if we just keep it in a simple idea that the kidneys will always remove things in excess, then that works out perfectly. Because if I do, now have excessive sodium, what are we going to do with it? Well, we'll pee it out, but now our pH isn't such a big deal, right? So it's a lot to think about. Let's go back more simplistic again, because I could just keep talking for days and days and days about how this changes sometimes. But let's keep it simplistic. But yeah, absolutely, everything you said is correct. So afferent arteriole comes into the glomerulus, efferent arteriole comes out. Bowman's capsule is going to capture everything, and the main role of that glomerulus is to filter. So your glomerulus ends up being what we call the major filtration unit. And again, filtering is not based off of anything active. It's not using pumps and gated channels. It's just filtering based off size. So when we go through this filtration at the glomerulus, I'm actually filtering out both good and bad substance. Okay? Things that the body could use and probably want to keep, and things that the body would actually want to get rid of, right? So now we're heading into the tubular system, and the tubular system will actively sort through this stuff, right? And your tubular system's a hoarder. A lot of stuff that ends up coming through this tubular system, if you're pretty healthy, should be good stuff, right? So you got a lot of good coming in here, because it's based off the idea that if your kidneys are already healthy, if we compare a blood sample to urine, right? What's urine primarily going to be composed of? Water, waste, with a little tiny bit of good stuff, maybe. It's okay. We have certain thresholds. It'll come out. But most of urine's water and waste, right? The waste is what we're trying to get rid of. The water is to help flush it out, right? In adequate amounts. And at the same time, it's going to maintain proper fluid volumes, because we get thirsty and we drink and we have to remove any excess, okay? And then here in blood, if we're comparing the two, your blood should be water, cells, right? Proteins and nutrients, with a little bit of waste, right? So I know I'm adding a little bit more there than I did previously, but waste is always present. Nutrients are always present in the blood. If we're healthy, nutrients should be making up the majority of what's floating around in the plasma. The waste should be pretty minor. So as we're going through this tubular system, how are we maintaining all that good stuff in the blood? If I'm filtering out at the glomerulus, we quickly reabsorb it. So if I do have good and bad coming out in healthy blood, you should have more good than what you have bad naturally, right? So there's a lot of work that needs to be done at this proximal convoluted tubule. So what ends up happening with this efferent arteriole right here is it'll come out here. I'm just going to draw it really lightly. It'll come around here, and it's going to circle around this tubular system. I know you can't see that very well. That's on purpose. I don't want to glob up the image, right? But this efferent arteriole is going to end up forming a peritubular capillary. That's what that is. And that peritubular capillary is now going to give access for your tubular system back to the blood of the body. So if I go through a process called tubular reabsorption, which mostly occurs at the proximal convoluted tubule. It can occur anywhere in here if you want to, but most of it occurs at the proximal convoluted tubule. You're going to be pulling all the good stuff back in, right? So you're going to pull that good stuff back into the blood, where it's going to now float around and be available to the body again. So we're not going to allow a lot of good stuff out, right? Most of that gets reabsorbed. Okay, but the bad stuff stayed behind. So this is gone now. This is gone now. This is gone now. What's left? Bad, bad, bad. And of course, enough water to carry it out. And we can change how much water is going to leave with it, usually right in here, in that loop of Henle. That loop of Henle is going to allow us to concentrate this appropriately. But anywho, you got water and waste, water and waste, water and waste. But let's say we're generating waste at a higher level. Like let's say I'm exercising and I'm producing more acid. That acid is going to be floating around in the blood. You know, some of it's going to be in the form of CO2. Some of it's going to be in the form of hydrogen ions. The lungs can take care of this. And by getting rid of this, I'm also going to get rid of that. But still, you're going to have more of this floating around in the blood. So we want to get rid of that so we can actually add it directly to the tubular system if we want to. And again, I'm just using that as an example. But this could be, say, bad, bad, bad if it's in excess, and we can add that directly to the tubular system. Okay, so simplified version, your kidneys, one of the job of the kidneys is to remove chemical waste. And even though waste is variable, the waste is going to be considered bad if it accumulates too much, right? Because we don't want to become hypernatremic. We don't become hyperkalemic, right? Even though sodium and potassium are normally considered good for the body, if you have too much, it's bad, right? So waste is going to be anything in excess, it's going to be considered bad. As you're going through the nephrons, which are the functional units of the kidneys, you have two major functional parts. You have a glomerulus and you have a tubular system. Your glomerulus is just a capillary, right? It's just a capillary. So all it can do is filter. It can reabsorb a little bit, and that'll happen with diabetes, but we're not worried about the reabsorption part. We're just worried about the filtration part. So when you filter in this glomerulus, you're going to be filtering out both good and bad substance, good and bad. Okay. But as I go through this tubular system, most of the good stuff gets reabsorbed through a process called tubular reabsorption, leaving behind the bad, which is the waste. That will continue through. And if we need to add extra bad in from, say, the body to the tubular system, we can do that through a process called tubular secretion. All right. Put all three together, you have glomerular filtrate plus tubular reabsorption plus tubular secretion. Now you have normal kidney function for the process of developing urine. And a lot of times it's mentioned in a kind of roundabout way, like here. Like if you're talking about total urinary excretion, it's glomerular filtrate plus tubular secretion, because that's what we're adding to the tubular system minus tubular reabsorption. So I'm adding stuff to the tubular system here. I'm adding stuff to the tubular system here, but I'm also pulling out of the tubular system, right? So I'm adding stuff to the tubular system through the glomerulus. I can add stuff to the tubular system through tubular secretion, which is going from blood directly into the tubule, right? From peritubular capillary. And whenever we're adding stuff to the tubular system that doesn't get pulled back out again, that's what's going to be your final urine product. So glomerular filtrate plus tubular secretion minus tubular reabsorption is what's going to end up being in the urine. But again, the way we're going to think about it is my glomerulus is going to filter out good and bad. My tubular system is going to pull all the good stuff back out again, and we're going to keep it. So that's going to be tubular reabsorption. All right. So bad stuff still in here, right? Because we add it bad through the tubular, or through the glomerulus. So that's still in there. It's floating around. And then if I need to add more bad, we can do that through a process called tubular secretion. And that'll give us our final urine product, which should be mostly water and waste. Easy peasy. So that's basics of the nephron. And we'll take a break. We'll take a break. We are going to take a break. Let's see, it's 11:15 now. Let's take a break. Take a break till, let's say 11:30. Take a 15-minute break, and then we'll finish up talking about capillary macula densa, GFR, renin-angiotensin aldosterone pathway, and then we'll call it a day. So Let me pause the recording. So picking back up where we left off, we had talked about the anatomy. You know, here's a kidney, a ureter, bladder, urethra. Why do we care? Because urinary tract infections can get in there and cause all kinds of problems. Talked about the basic functions of the kidney. Removing chemical waste is one of the big ones. And to do that, we have to maintain proper blood pressure, blood volume, electrolyte balance. Talked about the nephron, which we just got finished doing. Basic idea, like what are the parts? You have a glomerulus that's fed into by an afferent arteriole. Exiting from the glomerulus is an efferent arteriole. Surrounding the glomerulus is a Bowman's capsule. And then attached to that is a tubular system, which is made up of a proximal convoluted tubule, a loop of Henle, a distal convoluted tubule, and a collecting duct. And when you subdivide the nephron into two functional parts, the glomerulus is your major filtration unit. The tubular system is your more selective portion. It's going to sort through all that stuff, determining the stuff that we're going to keep versus the stuff we're going to get rid of. And at the end of the day, we should be peeing out waste and water, right? But when we got into the nephron, the glomerulus, which is an extremely important part of it, because that's how the whole thing gets started. You know, I can't sort through waste if I don't have stuff to sort through to begin with. So the first step of waste removal is we have to take it through that glomerulus, which is a capillary. So real quick, basics of how a capillary works. Here's an artery, arterial, capillary. And normally we have venial vein, right? Obviously it's different when you're in a glomerulus. Here's an afferent arteriole. Here's a glomerulus. Here's an efferent arteriole. So why are we leading into a capillary? This is all capillary. It's just, again, all twisted up. Why are we leading into a capillary with an arteriole like normal, but then exiting as an arteriole? Because eventually we're going to go on and form another capillary. So capillaries come from arterioles. So it's okay, no big deal. As long as the pressure coming in here is greater than the pressure that's exiting there, it'll flow just fine. And pressures are important because when you get into normal capillary function, of course, we usually talk about filtration versus reabsorption, right? And that occurs in the glomerulus too. Like you do have filtration. There is a little bit of reabsorption that occurs, especially when you're like really dense in certain nutrients. Like if I'm diabetic and I have a lot of sugar in this, that's going to generate a lot more osmosis and you'll reabsorb more. And then we end up having to recirculate this blood again. So you end up peeing a lot more with diabetes because this blood recirculates around again. But for the most part, let's talk about normal healthy function. The majority of the time when we're mentioning the glomerulus, we care about it because it's the major filtration unit. And filtration, of course, is the pushing of substance and ions from the blood, or you could call it the plasma. That's the portion of the blood that's filtering. Or you could call it the intravascular fluid, whatever you want to call it. We've called it different things in different chapters. Sorry. Become very dyslexic when I'm writing out things, but intravascular fluid, that's what we're filtering. And one key thing to remember is when we're filtering blood, blood is a connective tissue, right? Which is made up of cells, proteins, and the extracellular matrix, which is, again, the plasma. So the part that we're filtering is this part, not that part. Those are too big. So those don't go through the filtration because they get left behind. They're too large. So one thing that I always tell people is in normal capillaries, things that do not filter is your short list. Because again, when you go back to last week's discussion about blood, blood is a connective tissue, right? You have red blood cells, white blood cells, and platelets. You have plasma proteins, and then you have the plasma, which is also going to be rich with lots of substance, right? But when you're going through filtration, it's only the small things that leave, the stuff that's small enough to dissolve in the plasma. Cells and proteins should not. So things that do not filter should be cells and plasma proteins, right? So if that's the case for a normal capillary, here, that should also be the case for a glomerulus. So what's filtering out from the blood to the interstitial space is, again, small stuff, right? Things like electrolytes, nutrients. Hold on, let my dog out. He's sniffing around. Give me 1 second. So the things that are filtering are the substances that are small enough to float around and be dissolved in the blood plasma, right? Things that should not filter are the things that are too big, right? Because if I'm too big, I shouldn't fit through these little openings. That's the whole idea of what a filter is and how filtration works, right? And so in order, though, for this filtering mechanism to occur, I have to have enough pushing power. So that's another reason we're discussing a capillary again, right? Because when you get into a capillary, another idea that we mentioned was the main driving force for filtration, right? So filtration, let's say, is the pushing of substance and ions from the blood to normally the interstitial space, right? In a glomerulus, we're going to change that a little bit. So when we're in a glomerulus, we're a capillary again, but we're pushing into the Bowman's capsule. Okay. But it's the same idea. It's the pushing of substance and ions from the blood somewhere. So normally it's the interstitial space. Now we're pushing into the Bowman's capsule, and the Bowman's capsule is going to capture it, pass it along to the tubular system. What are things being filtered? Anything small. What are things that should not be filtered? Cells and plasma proteins. So if I start seeing cells and plasma proteins in the final urine product, that's a bad sign, right? Because that means somehow they escaped out of here, which should be very small. You know, it's a small filter. Why are big things leaving? Maybe inflammation, right? So if I have some type of glomerulonephritis, then maybe you'll see extra protein in the urine. Maybe you'll see red blood cells or white blood cells in the urine, right? If I have physical damage to this, maybe you'll see red blood cells and protein in the urine. Too big of things are leaving. If you see big things leaving in the final urine product, that tells you where your damage is occurring. It's this capillary right here, because small things should be the only things that leave. We shouldn't see big things. But instead of pushing from substance and ions to the interstitial space, we're now pushing substance and ions from the glomerulus into the Bowman's capsule. That's going to capture it, right? We still have to have a pushing power. So what's causing this pushing is CHP. So what is the main driving force for filtration? The main driving force for filtration is CHP, right? And of course, we get a little bit of help from ICOP. We're not going to worry about that one today. We're just mainly talking about CHP. So what's CHP? Well, in a capillary, it refers to capillary hydrostatic pressure, which is the pushing power of fluid inside of a capillary. And because capillaries are naturally permeable, they have openings in their walls. When you push them, they spread open a little bit. It allows substance to escape, right? But would I call this pushing power the same here or here? If it's not in a capillary, of course not. You know, we call it capillary hydrostatic pressure because it's water pressure pushing on the walls of the capillary. That's what's going to allow filtration to occur because capillaries are permeable. But arteries aren't permeable, arterioles aren't permeable, and they're not capillaries. So back here, we don't call it capillary hydrostatic pressure. We simply call it blood pressure. So blood pressure is going to be the main driving force for capillary hydrostatic pressure. And blood pressure can be altered in different ways. Right? I can change how much vasoconstriction is going into a vessel. I can change heart action, right? I can change how hard the heart's beating, all that kind of good stuff. But one of the most directly proportionate things to blood pressure was blood volume. That was mentioned back in cardiovascular. So when the kidneys look at capillary hydrostatic pressure, right? They're basing it off the idea that blood volume is one of the main driving forces for blood pressure, which is true because the most directly proportionate thing to blood pressure is blood volume. So as blood volume goes up, blood pressure goes up. As blood volume goes down, blood pressure goes down. It's directly proportionate, right? So it's important too, because blood pressure is what's going to generate CHP. And in the kidney, that CHP is going to generate our GFR, right? Which is going to be the glomerular filtration rate. So in some books, what you might end up seeing is CHP gets changed to GHP, which is unnecessary because it's just saying glomerular hydrostatic pressure. But what is a glomerulus? It's capillary, right? Your glomerulus is a capillary that's trying to filter out all the small substance floating around in the blood plasma. Again, it's both good and bad. It's not discriminative. It's just pushing out anything that's small through filtration. So your glomerulus equals your major filtration unit, right? And it's pushing all the small substance that's dissolved in your blood plasma along with water to carry it into the Bowman's capsule so your tubular system can sort through it. What should not get filtered out? Cells and plasma proteins, because they're too big. What's driving this filtration? Same thing that drives filtration in other capillaries, capillary hydrostatic pressure. And what's driving capillary hydrostatic pressure? Blood pressure, right? But if I don't have adequate blood volume, then blood pressure is going to become affected. So these are all important to the kidneys. So one of the first things that we talked about when we were talking about some of the roles of the kidneys or functions of the kidneys is, yes, your kidneys are supposed to remove chemical waste, and chemical waste can be anything that's in excess, but we also have to maintain proper, right, blood pressure. We also have to maintain proper blood or fluid volume, right? Because if we don't maintain proper blood pressure and fluid volume, then our glomerular filtrate, the pushing of substance and ions from the glomerulus into the Bowman's capsule, this is what we might call glomerular filtrate right here. This substance that's being pushed out, that's called glomerular filtrate. That's what's going to go into the tubular system so we can sort through it. If I don't have proper blood pressure and proper fluid volume, then I'm not going to have proper CHP, or we could call it GHP. And if I don't have proper blood pressure and blood volume, so again, blood volume contributes to blood pressure. Oops. Blood pressure is going to contribute to CHP. And in this case, CHP is also going to contribute to our GFR, which is the rate at which glomerular filtrate is being produced, right? And if I can't produce enough glomerular filtrate, then I'm not going to be able to remove chemical waste fast enough, because your body's always metabolizing, your body's always making waste. So we need to remove waste at a consistent and constant level, right? And we start removing waste through the glomerulus, because we're going to filter out both good and bad. We're going to then sort through that, reabsorb the good, kick out some extra bad, and that's waste removal, right? So this has to be happening at a constant rate. We call that the GFR, or the glomerular filtration rate. Okay, so if you want to put it all together in a very short little line, blood volume is one of the most directly contributing factors. It's the most direct, but it's also one of the most important contributing factors to blood pressure. It's not the only. You know, I can have low blood volume, but I can increase the amount of vasoconstriction. So if you have a patient that's hypotensive, it certainly could be because they're bleeding, but I could also bring their pressure back up if I just give them more vasoconstrictors. But again, if my blood volume is low, we can expect blood pressure is going to drop, right? And so if blood volume goes down and blood pressure goes down, that means CHP is going to go down. And if CHP goes down, that means GFR is going to go down. And if my glomerular filtration rate goes down, that's a problem, right? Because if GFR goes down, that means I'm not getting enough substance into this Bowman's capsule to sort through. So my tubular system is not going to have enough stuff to work with. So if I'm trying to get rid of waste or bad stuff at an adequate rate, and I'm not filtering fast enough, this stuff's going to accumulate in the blood because I'm not getting rid of it fast enough. So if my GFR, my glomerular filtration rate goes down, problem. Okay. So we need to monitor this. And the role of monitoring GFR falls on the certain cells of the macula densa. So macula densa is an anatomical location. It's kind of a structure, kind of whatever. Here's an afferent arteriole. Here's an efferent arteriole. Here's a glomerulus. Okay, here's a Bowman's capsule. Here's a proximal convoluted tubule right here. Convoluted just means it's all twisty, tortuous. Here's a loop of Henle. I can tell it's a loop of Henle because it's going down. Okay, so whether I go this way or this way doesn't really make any difference. Proximal is going to be one that's between the glomerulus and the loop of Henle. Distal is going to be the one that's between the loop of Henle and the collecting duct. So this could come this way if it wants to. Sure, no problem. There we go. There's another example of a nephron right there. But in this case, you can see, so here's our loop of Henle. So it's going down here, coming back up here. So as the descending limb of the loop of Henle goes back up, it becomes what's called the ascending limb of the loop of Henle. And as that ascending limb of the loop of Henle passes in between my afferent and efferent arteriole, you end up getting a large cluster of specialized cells right here, okay? And that large point of specialized cells we call the dense point, the macula densa. It's a dense point of specialized cells. So some cells are just called macula densa cells, and their job is just to make sure this area stays clean. They're like janitors for the glomerulus, right? They're going to keep it clean, remove any excess protein, all that kind of good stuff. But more importantly to us on normal homeostasis function is we also have these specialized cells mainly in the walls of the afferent arteriole here. They're spread throughout the macula densa, but mainly in the walls of the afferent arteriole here. And those cells are called juxtaglomerular cells because they're right beside the glomerulus, right? So here they are right here, right there, right there, right there, right there, right there. Those are juxtaglomerular cells. They're mainly found in the walls of the afferent arteriole. They're part of the overall macula densa, where the ascending limb of the loop of Henle passes in between the afferent and efferent arteriole, right? And what they're doing is they're monitoring how much of this is happening. And this is filtrate right here coming out of the glomerulus. So glomerular filtrate, right, has to occur at a certain rate or a certain amount over time. So we call that the GFR. Right. And if GFR ever goes down, that's a problem because that's going to decrease the amount that we can send into our tubular system, decreasing the amount that's eventually going to be able to leave. Eventually, waste will start to accumulate in circulation, and that's going to lead to kidney failure because kidney failure or renal failure, you can describe in two ways. You can say it's either a decrease in GFR over a certain period of time under a certain percentage, or it's an increased waste in circulation. And kidney failure doesn't have to be permanent. It can be acute. It can be short term, but it's usually caused by a decrease in GFR or maybe stuff in GFR is not working right, increased waste in circulation. Either way, it's renal failure. So we'll discuss all that next week. But we have to maintain GFR all the time. And if we are not able to maintain GFR because we have some type of change in, say, fluid volume, we need to compensate for that, right? So that is where something called the renin-angiotensin-aldosterone pathway comes in. So key points of what we just talked about. In the macula densa, we have these specialized cells called juxtaglomerular cells, right? Mostly found in the walls of the afferent arteriole. So cells that are mostly found in the walls of the afferent arteriole. And their job, the role of the juxtaglomerular cells is to monitor GFR, okay? And if GFR ever goes down, then these juxtaglomerular cells are going to be able to kick out renin, right? And renin is going to initiate what's called the renin-angiotensin-aldosterone pathway, okay? So we're going to write that on a different sheet of paper. I don't like having this background. But your renin-angiotensin-aldosterone pathway, or sometimes abbreviated the renin-angiotensin-aldosterone system, starts something like this. Let's say blood volume goes down. Let's just say that this is the case. Let's say blood volume went down, and that caused blood pressure to go down, and that caused CHP to go down, and that caused my GFR to go down. Then this would initiate the renin-angiotensin-aldosterone system. Why? Because anytime GFR goes down, for whatever reason, it doesn't have to be that particular phenomenon. I mean, that's what the body thinks is happening. Anytime GFR goes down, and it's going to compensate for that. Anytime GFR goes down, it doesn't have to be, though. I can have a decrease in blood pressure without necessarily affecting blood volume because I took too many vasodilators, right? I could have normal blood volume and still have a decrease in blood pressure, right? I could have normal blood volume and normal blood pressure throughout the body, but I can still have a decrease in GFR because I can't get blood to the kidney. That could be a problem, right? So I can still have a decrease in GFR because I have some type of renal artery embolism, like a blood clot that's blocking just renal artery flow, you know? But clearly that would decrease local blood pressure, even though blood volume overall is normal. But anytime GFR goes down for whatever reason, we're going to initiate the renin-angiotensin-aldosterone pathway or the renin-angiotensin-aldosterone system. And this is the strongest initiator of the renin-angiotensin-aldosterone system. It's not the only one. You can also stimulate this with the sympathetic nervous system, which would make sense because of what it does. But if GFR ever goes down, juxtaglomerular cells, right? So juxtaglomerular cells, these guys, right, which happen to form in the walls of the afferent arteriole mostly. If they notice that my GFR is not like this, but instead is just like this. So here we have normal GFR. Here we have a decrease in GFR. These juxtaglomerular cells will start releasing renin. Okay, and it's going to go into the blood. You know, this is all blood vessels. So the renin is going to go directly into the blood. So if we have a decrease in GFR, juxtaglomerular cells will release renin. And renin is a hormone. Okay, and hormones usually work by getting pushed into bodily fluid, mostly blood, and then they'll transport and they'll affect anything that has receptor sites for that hormone. Okay. One thing that really responds to renin is actually already in the blood to begin with. And it's a plasma protein in the form of, and this arrow is going to kind of go this way in a second, but it's a plasma protein in the form of angiotensinogen. Okay. So OGEN endings mean I'm an inactive precursor to whatever's in front of it. It's the same as a pre or pro prefix. An OGEN suffix means this is inactive. Okay. So what is angiotensinogen? It's an inactive precursor to angiotensin. Okay. So angiotensinogen is a plasma protein, something your liver makes, right? Specifically for the blood, and it floats around in the blood until it's needed. To activate it, though, I need renin. And renin will cleave that angiotensin slightly. It's kind of like it's all shut off like this. It's not very social, right? And renin can open it up a little bit, right? But it's still not going to be functional. We're going to have to open it up further. So it's going to have to go through a pathway. But the initiator of the pathway is a decrease in GFR. And because GFR went down, juxtaglomerular cells released renin. Renin's going to open up angiotensinogen just a little bit. So angiotensinogen, which is a plasma protein, in the presence of renin will start becoming angiotensin 1, and this will start to accumulate in the blood, the presence of angiotensin 1. What's the effects of angiotensin 1? Very minimal vasoconstriction, because the word itself tells you vessel tension, vessel tension, angio, vessel, tensin, tension, right? So angiotensin 1 is a very weak vessel constrictor, okay? But it's not strong enough to really do anything. So as this process is occurring in the blood, we're going to circulate throughout the whole body. We'll pass through the lungs, and in the lungs, we're going to come in contact with a specific enzyme called angiotensin converting enzyme. Okay. And angiotensin converting enzyme will convert angiotensin 1 into angiotensin 2. And angiotensin 2 is a very strong vasoconstrictor, right? So just in the presence of angiotensin 2 alone, we can go ahead and start reestablishing blood pressure, right? Because even in a low volume state, if a patient is hypotensive and you give them angiotensin 2, their blood pressure is going to go up. That's how you can reestablish blood pressure, right? But there's other things we want to do too. So we want to kind of tackle this whole thing from the perspective of the renin-angiotensin-aldosterone system. Not only do I want to fix low blood pressure, I also want to make sure if I have a decrease in blood volume, it's not going to get any worse, right? So in the presence of angiotensin 2, you're going to have three kind of essential effects. You're going to have general vasoconstriction, but one thing we're going to do is we're going to vasoconstrict walls of efferent arteriole, which is going to help us to reestablish GFR. Almost immediately, it'll help us reestablish GFR, even in a low blood volume, blood pressure state, right? Because we can locally constrict the walls of the efferent arteriole, and what that'll do is that'll block off the exit here. So even if I got less blood coming into the glomerulus, if I block off the exit by constricting the walls of the efferent arteriole, like doing like this, it's going to create traffic or congestion in here, and that can help reestablish GFR, even in a low volume, low pressure state. So that's nice. But we're going to also need to tackle this from a bigger perspective. Like, how did we get there to begin with, right? So again, the body thinks it's probably because we're lower in volume and that's caused a decrease in pressure. So we want to tackle both of these. So one thing we're going to do is we're going to increase aldosterone production from the adrenal cortex, which of course is part of the adrenal gland that sits above the kidney. And specifically, it's coming from the outer portion of the adrenal gland. So we'll call it the adrenal cortex. And aldosterone we'll talk about in just 1 second. And then the other thing we're going to do is increase ADH production coming from the hypothalamus. ADH is also known as vasopressin. Okay. So how do these things contribute to this idea we'll talk about next? Aldosterone, again, was something we call a mineralocorticoid, and it comes from the adrenal cortex. So here's your kidney. Here's the gland that sits above the kidney. So this is renal, this is adrenal, sits above the renal, right? And the outer portion of the adrenal gland is called the adrenal cortex. And in your zona glomerulosa, I'm just saying that just because it's repetitive, we create these things called mineralocorticoids, which can help us sort better and maintain proper levels of some of our very important ions like sodium and potassium. And the most important of those mineralocorticoids is aldosterone, right? Because in the presence of aldosterone, let's just say this, if we increase our aldosterone production, that will increase my sodium reabsorption rates. And because water likes sodium best, that's also going to allow us to reabsorb water at a higher rate. So I can show you a picture of how that happens in a minute if you want me to. And at the same time, since we're going to be conserving sodium, which is a positively charged ion, I need to get rid of equal amounts of positively charged ions. So we're going to get rid of potassium at a higher rate, right? By secreting it directly into the tubular system. So what does the presence of aldosterone do? Increases sodium reabsorption, which is going to allow us to hold on to water better, getting rid of potassium, right? So schematically wise, how would that look? Let's say here's my glomerulus, here's my Bowman's capsule, here's my tubular system. Most of the effect's going to be happening in the tubular system, okay? Where if I increase my sodium reabsorption rate, right, we're going to start pulling sodium out of the tubular system because it gets filtered in there every time. Sodium's small, obviously. It's very plentiful. It's the most abundant extracellular ion, so it's going to get pushed into here a lot. There's going to be a lot of sodium that goes into the tubular system, right? But under the influence of aldosterone, we can pull more sodium out of the tubular system and it stays behind. Because if I leave the tubular system, you know, before I go down the collecting duct, I'm staying in the body. So let's just assume this is body, 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 right? So if I get pulled out of the tubular system anywhere, like whether it's here or here or here or here or here, it doesn't matter. If I get pulled out of the tubular system, I'm staying in the body. I'll get pulled back into the blood. Anytime you pull sodium out of the tubular system, water will follow, right? So that's one of the main roles of aldosterone, again, is it increases sodium reabsorption. So tubular reabsorption means I'm going to pull it out of the tubular system back into the blood or back into the body, right? But at the same time that I'm pulling these positively charged sodium ions, I can't malaffect the overall charge of the body. So we need to get rid of a positively charged ion too. So we're going to increase our potassium secretion, meaning I'm going to take some potassium that's floating around in the blood, kick it into that tubular system so it leaves at a higher rate, right? So we're going to increase potassium secretion. And that's okay. That's normal. Potassium is most useful inside of cells, not outside. It's not an ECF ion. So if we're getting rid of ECF potassium, that's okay, which that's what we're doing. Don't worry about that, but we're going to get rid of it at a higher rate. So aldosterone increases sodium reabsorption, increases potassium secretion. Why do we care about the sodium reabsorption? It's mainly because of the water, because that'll control where water goes. Because water can freely move through cell membranes, water can freely go wherever it wants, but we need to control the stuff that water likes. So if I can hold on to sodium, that means I hold on to water, right? And big picture wise, the whole reason we started the renin-angiotensin-aldosterone system is because we're under the assumption that blood volume must have gone down and that caused a decrease in blood pressure. Again, it didn't have to happen, but that's what we're assuming at the kidney level. Kidneys don't have eyes. They can't see what's going on. All right. That's going to decrease GH or CHP, and that's going to decrease GFR. It's the decrease in GFR that started this whole problem. But by increasing my sodium reabsorption rates, which is going to hold on to water better, that's going to keep blood volume from going down any further, because I'm going to retain water now. I will retain water. All right. So this isn't going to go down any further. Okay. So that's the role of aldosterone. Going back, another function that we saw. So why do we increase our aldosterone production? Because it's going to help us retain water, right? Another function that we saw is we're going to increase our ADH production. This will help us retain water because it's an antidiuretic hormone. So ADH stands for antidiuretic hormone, which means don't pee hormone, right? It's pulling water out of the tubular system, because when I filter, water is what's generating the capillary hydrostatic pressure. Hydrostatic pressure, water pushes it out. That's what's carrying these substances, through the tubular system. So water is always present in the tubular system, and it's going to have, again, good stuff and bad stuff floating around with it. Hopefully we'll pull all the good stuff out, but the water stays behind. But how much water stays behind depends on how much we need. And if my blood volume is going down, then we want to pull as much water out as possible, but still leave enough to where we can get the waste out. So we got to be able to get that waste out. So we got to leave some water behind. But we can really, really concentrate that waste if we need to, only leaving a very small amount of water with it. And one way we can pull water out of the tubular system, again, is in the presence of aldosterone. But that's going to be pulling out water because it's following sodium. But another way we can pull water out of the tubular system is in the presence of antidiuretic hormone. And antidiuretic hormone can pull water out without changing sodium levels. So let's say sodium levels are just right in the body and I don't want to pull that out. Well, ADH can do that for you. So that's nice. But usually they'll work together. So if I have ADH, again, that's going to help me conserve water. So both aldosterone and antidiuretic hormone help conserve water. But another thing that we want to do is we want to reestablish pressure regardless of what's going on with the blood volume. We need to establish pressure regardless of blood volume. So I can do that in the presence of vasoconstrictors, right? So one vasoconstrictor we already mentioned was the presence of angiotensin 2, right? But another very, very, very strong vasoconstrictor that we just produced was vasopressin, which is just the same thing as ADH, it's just another name. So ADH helps you conserve water because it's antidiuretic. It's saying don't pee so much, hold on, right? But it's also called vasopressin because it's the strongest vessel compressor that we have, right? So that's going to help us, again, reestablish blood pressure. So overall, the renin-angiotensin-aldosterone system is going to help conserve fluid, so this doesn't go down any further, and increase blood pressure. So that'll then increase CHP, that'll then reestablish GFR, and now the kidneys can work again, right? So this runs all the time. It's running all the time. But sometimes it's going to run more than others. Like if I'm very dehydrated and I'm working hard and I haven't drank a lot all day, and you go and you pee and your pee is very minimal, it's very dark, it's because we're running the system very strongly. Right? But there are certain times where this system is going to be counterproductive, right? Like if I am, let's say, hypertensive, like let's say I have high blood pressure, which many Americans do I want to run the renin-angiotensin-aldosterone system? Probably not. Because if I am running the renin-angiotensin-aldosterone system all the way to the end, I'm introducing two very strong vasoconstrictors and I'm retaining water. So you're having two very strong vasoconstrictors, plus you have aldosterone, which will retain water. So retain water, vasoconstriction, right? So angiotensin 2 is a strong vasoconstrictor. Vasopressin is a very strong vasoconstrictor. And then you have aldosterone retaining water and ADH, which is the same thing as vasopressin is retaining water. So do you want that if you're hypertensive? Hell no, right? That's the exact opposite of what you want, right? because hypertensive patients, a lot of times they have too much fluid volume already, and they're already too tight in the vessels. So by running the renin-angiotensin-aldosterone system to the end, if they're already hypertensive, it's only going to make them worse. So maybe you would give them an ACE inhibitor, right? Preventing the production of all that stuff. But that is our review of all the basics. So if you want to see slightly more clear writing, here talks about the macula densa, juxtaglomerular cells. Here's a simplified picture of that. Here's afferent arteriole, efferent arteriole, glomerulus, Bowman's capsule, proximal convoluted tubule, loop of Henle. Here's the ascending limb of the loop of Henle passing in between afferent and efferent arteriole. Here's a macula densa. Here's your juxtaglomerular cells right here. Monitoring GFR in here, right? GFR ever goes down, then we're going to run the renin-angiotensin-aldosterone system or pathway. So that's right here. So again, same thing that we just wrote down. So next week on Tuesday, we're going to pick up with the urinary again. So we are on week 8 right now. We're just finishing up our Zoom meeting for 7:20. Tuesday next week, we're going to talk about when all this stuff gets broken. Like what happens if I don't produce enough aldosterone, right? What happens if my kidneys are damaged, and how can kidneys be damaged? What happens if I don't get enough blood to the kidneys? What are common causes of kidney problems? What do we see on labs maybe? So we'll talk about that on Tuesday. And then a week from today, we'll start getting into the digestive system too, which will push us into our final week, where we're going to finish talking about digestive in the liver, cancers in neoplasm, and that's going to wrap up our semester. So now you should be able to see all the modules. I opened these up today, so those are now available. But again, we're just finishing up right here currently. If you're not caught up with us at this point, try to get this stuff done by the weekend, so that way you can focus on new stuff going forward. Muscles, we didn't really cover on Tuesdays. I just gave you a little list of things to look up. All right, just a little short list of things to look up. But again, today we just talked about the basics. So we did the anatomy, we talked about functions, we talked about the nephron, we talked about capillary function, macula densa, GFR, renin-angiotensin-aldosterone pathway. That's where we left off. And so Tuesday next week, we'll talk about some of the pathophys with that. I'm going to go ahead and stop the recording.